Hi there, this is Dr. Rob Cywes, the Carbaddictiondoc. This little mini-series of episodes is about bariatric surgeon. I am first and foremost an obesity doctor. In other words, my entire approach is to treat carbohydrate addiction. Surgery does not do that. However, there are a certain group of people who try really hard with the ketogenic diet and struggle, or they are so heavy or so sick with diabetes or metabolic syndrome that the slope of the weight loss curve needs to be steepened or needs to be continuous rather than the repetitive relapses. And under those conditions, obesity surgery, weight loss surgery is a very, very effective tool to help people to get to an endpoint and then continue to treat their obesity. It helps you to get rid of type 2 diabetes, to stabilize that. It helps you to lose a huge amount of weight. All of that is transitional or transient unless you treat your obesity. Look at the previous episodes to understand this. However, this particular mini episode is about the sleeve gastrectomy, the laparoscopic sleeve gastrectomy. Essentially, the two principles of weight loss surgery are, number one, to reduce how much you can eat and keep you full for a long period of time so that you don't eat that often. And the principle of caloric reduction is to reduce the quantity and decrease the frequency with which you eat, which results in overall caloric consumption. That's called a restrictive operation. The flip side, which we'll talk about in the next episode, is a metabolic surgery. And basically the principle is, well, these fat people are never going to change their way. Why don't we sew their arsehole to their mouths and get them whatever they eat, they just poop out. I know that's a little bit facetious, that's a little bit silly, but essentially the metabolic surgeries allow you to eat whatever the devil you want to, restrict some of what you're eating, but basically bypass the absorption part of your intestinal tract. It's great for weight loss because you poop out the calories, but it ain't so good for nutrition because not only are you pooping out the calories, you're also pooping out the nutrients. And typically those patients, no matter how skinny or how fat they are, become malnourished. And I have some concerns which we'll express in the next episode about the metabolic surgeries. But this episode is about the Mac Daddy, the operation I love the most. I used to love the band. This is an upgrade of the band. I still love the band, but the sleeve gastrectomy, the laparoscopic sleeve gastrectomy, is in my hands and in my opinion, the gold standard. It is a pure restrictive operation, which means you absorb what you eat. So the risk of malnutrition is extremely low unless you don't put real food into your face. But as long as you put real food into your face, what you eat, you will absorb. It's kind of a misnomer because the word sleeve is not something we put on the stomach or around the stomach. Essentially, the sleeve gastrectomy is about converting this big bag that is your stomach that requires a huge amount of food to fill. What we do with a sleeve is very, very simply remove the baggy part of the stomach with a stapler. Yeah, that part comes out. And we turn the big bag into a tube. And that tube we call a sleeve. And there's a staple line all the way along here that heals up over the space of about 3 weeks. So what happens when you eat a small amount of food, it sits there and it slowly travels through here. You just don't feel hungry at all. And no matter what you eat in the first year or so, you lose a dramatic amount of weight. But slowly over time, the sleeve opens up just a little bit. It never stretches. That's garbage. Oh, my sleeve stretched out. The stomach doesn't do that. It was either an incorrect operation, I'll talk about that in a second, or it popped open a little bit, but it's never about the width of the sleeve. It's always about the frequency of the traffic and the type of traffic that goes through there. However, but it does open up just a little bit. In my hands, I put a stitch over the top of the staple line so that it's very, very narrow to begin with, which is what you want. You want to eat a tiny amount of food purely for the nutritional value. The calories don't go in because you can't eat them, and you lose a dramatic amount of weight in the first 3 to 6 months as you adapt the behavioral side, the obesity side. Then as you get closer down to a normal weight for you, I hate the word goal weight, there is no such thing, but a healthy weight, the sleeve opens up a little bit so you can eat a little bit more, but you level off. And if you've changed the obesity side of the equation, addressed your obesity, you lose the weight and you keep it off. Sure, you can gain weight on the sleeve, more difficult than the band. And is it possible to undereat? Sometimes, although I haven't seen that. So the goal is to lose a dramatic amount of weight, change the behavior, and stay normal. But the cool thing about the sleeve is that it is incredibly safe. It's the safest operation out there. The critical times are the first 3 weeks when that staple line is vulnerable, but you're not hungry. If you just drink fluids, and we educate you on this, you survive those first 3 weeks absolutely fine. You learn how to re-drink, and then when you do start eating, it's small amounts that go through there, and you lose a dramatic amount of weight. After 3 weeks, that staple line is safe. What are the risks? The sleeve can bleed, although I very rarely see that. I've never ever seen that in my own hands. You can get a stricture or narrowing, or it can leak. And we see a lot of leaks that come from Mexico. Patients who didn't have the money to pay for the sleeve in America go down to Mexico, do the travel tourism thing. They come back in a week later. They come into the hospital. They got a leak. I can't take care of those patients. I don't have the capacity to take care of them. And a lot of those patients die. So a leak, while very rare in our hands, is a dramatic, awful complication. Where it's a leak from a bypass or a sleeve, it is an awful complication. Again, we very, very rarely have leaks in our hands, but if they do happen, we can manage them effectively with a stent. So while it may happen, it's extremely rare and it is treatable. On the flip side, it is the safest operation out there, and it is the least metabolically insecure operation. In other words, you keep what you eat. The weight loss is also the best of all the surgeries in a sustainable, non-malnutrition way. The other surgeries may cause weight loss a little bit more rapidly, but they all come with malnutrition. And that's my concern. I do not want my patients to go from being fat to being malnourished. That's why I love the sleeve. In my hands, the greatest problem is a maladaptation between how much and how quickly and the type of food you eat. And if that food sits in the upper part of the stomach, particularly in the first 2 or 3 months, the nausea and the reflux, it feels like reflux, but it's actually just food kind of getting trapped in the lower esophagus. Those feelings are miserable. And you either get all angry at your surgery, or you refrain from eating as much or as often, and always that nausea, that negative food getting stuck goes away. But you can expect that. Expect that early on, adapt your way of eating, adapt your way of life, and it goes away pretty quickly. The other key thing about the sleeve is every doctor out there makes it up as they go. The key principles about the sleeve: number one, every doctor should do a hiatal hernia repair or a cruroplasty, because even if you don't have a big hiatal hernia, by virtue of the fact that the sleeve is narrow, that area is going to dilate up. You're going to have problems with reflux afterwards. The second thing is, the staple line should be wide enough that you can eat, but narrow enough to restrict you. I've seen some sleeves where they just took off the bottom part of the stomach. They left a huge amount of stomach. And that's not in your best interest. The other thing about the stomach is, as you notice, the stomach actually sits like this, and it almost goes at a right angle. There's the upper part, the incisura, or this angle, and then a lower pouch. A lot of doctors just remove the upper part on a sleeve and they leave this big pouch at the bottom. That is not an appropriate sleeve, and those patients will gain their weight back. The Germans in several studies showed that you have to go around that corner and remove that prepyloric pouch as well. It has to be a tube all the way around. Otherwise, you can eat much more food and it sumps in the lower part of the stomach. You do not want that. And some of the failures I've seen in about a third of my practice is revision of failed surgeries. Either the surgery failed or the person failed. We have to correct the obesity for those patients, but also technically the usual problem that we see is that the pouch at the bottom here was too big. A lot of patients who previously had lap bands get converted to sleeves, and the one concern there is there can sometimes be a stricture or a narrowing of the stomach, and when you do the sleeve, that area stays fixed and narrowed and it becomes an obstruction. That's a concern, because the ultimate treatment for that is to convert to a gastric bypass, which we really don't want to do. We want to keep the sleeve. So it's very important, if you're going to have a band conversion, to do it with an experienced surgeon who understands that narrow area and opens that area up and leaves it slightly wider so that it doesn't have a problem. And then the final issue is sometimes you can get scar tissue around the sleeve that fixes it down. And that can cause obstruction as well. Under those conditions, you may need an endoscopy with some balloon dilation. And I typically find that those strictures or those narrowings or either the kink or the scar tissue occurs in people who are not having a sleeve as a first operation, but they're having it as a revision. They've had a previous failed sleeve, or they've had a lap band that's been taken out and reverted. Those are the patients that get into scar tissue problems. But In my opinion, the sleeve gastrectomy is the single safest, most effective form of restrictive weight loss surgery that's on the market. And we do a pretty darn good job about creating that source of restriction while still giving the patient the ability to eat. I love this operation, but it doesn't stand alone. It's an integrative part. The surgery has to be integrated with obesity management and a transformation in your relationship with sugar and starch. You do that, it will work wonderfully for you. Struggle to begin with as you adapt that behavior for a wonderful life afterwards if you do it effectively. If you want to know more about the sleeve gastrectomy, if you've had one and are having problems with it, understanding the obesity side, or think there are complications with it, please give me a shout. Text me to 561-517-0642 and we'll set up a consultation. We love to look at the sleeve under fluoroscopy, under X-ray dye in our office to see what it looks like, and we can immediately tell you whether the sleeve is effective or whether there are problems with it, and then potentially address those problems should you choose to desire to do that. Thank you very much.